questions? Yeah, sure. Questions?
Are there, anybody has any questions?
Thank you. I have a question. Back to the diffuse versus limited. So I've had scleroderma diffuse for like 18 years, and now I'm also anti-centromere positive, and also still scler 70 positive, and I'm in a big flare-up. What do you think about that? How often do you see that crossover?
That's really pretty, what you just described is, really pretty rare. And I would think you would have features of, both, possibly. But I think the probably Trump thing is probably how the sort of skin looks. And I think your skin kind of puts you more in the diffuse pocket. But I think, again, that's an excellent example of the autoantibodies. We always say it's the patient and not the autoantibodies. And I think doctors get overly in love with the antibodies, and so I think we have to be sort of flexible. I have a number of my lupus patients who have anti-centromere antibody positive too, and they do tend to have more of the Raynaud's than the average lupus patient, sort of my experience. Also, they might get some of the telangiectasias that are a little different, so they do have some features of the limited crest type of variant.
But it's not common to have like
No.
Of course.
Sure.
Hi, I have a question. Is it always skin that's first?
No. But it's true that most commonly skin will be your leading thing. But every year we get called to the wards to for someone who's having renal failure, and their kidney failure, kind of is sudden. They had this hypertensive crisis, and they had, it's usually a sort of an older man, and all of a sudden they will have their presentation of their scleroderma will be through their kidneys. Same for the lung. Because I'm doing a number of lung studies with the pulmonary group, we definitely have people who weren't diagnosed. The Raynaud's was either dismissed or not appreciated. They came and were short of breath and had a lung workup by their lung doctor, had interstitial lung disease, and that was the presentation of their scleroderma. Same thing for pulmonary artery hypertension. So each of those organ systems that I said could be involved can be your lead organ diagnosis, but though that's much less common. And oftentimes when you look at those patients, there is something subtly there on the skin that may have been missed. Our pulmonary colleagues, we kind of, we don't laugh, but I mean, when we come and see them, it's like obvious to me that the skins are, there's the nail capillary changes and there's all these other things, and they have just like missed it all. And we did at UCSF, we have done lung transplants on 27 scleroderma patients, and they all have done really, really well, but we wanted to publish that, so it meant we had to go back into all the data and find out how they presented. And it was clear that many of the outside lung doctors, even our internal lung doctors, weren't making the diagnosis of scleroderma properly. Absolutely, absolutely. Yes, GI could be the beginning site, absolutely, correct.
Have you heard of antibiotics helping to reduce the effect of the itching and the collagen bumps?
Yes, absolutely, and I think that I did have the minocycline on there on the calcinosis slide. So yeah, antibiotics have a array of beyond just being antibiotics. They also have antifibrotic properties and other types of properties, and so people have looked at them for scleroderma. There was probably about 10 years ago, there was a big, huge interest in it, and because I put acne patients on minocycline, I mean, I don't begrudge somebody if they want to try the antibiotics. But there was a study that was done by Maureen Mays, and she looked at a double-blind control of the minocycline, and this was published probably 5 years ago in the Arthritis and Rheumatism, and did not see a benefit under a double-blind control trial. So I know there's like the road back out there, there's all these other foundation, there's all these sort of people who will give you IV antibiotics, so there's a whole sort of world of the antibiotics out there. And my feeling is that, we just don't understand enough. I think it's reasonable to try them in a limited basis. In general, I don't think you get into trouble.
It's just personal experience that I asked that question because I was given a dose for, I scratched one of the bumps that got infected with staph, and what they gave me were, the dermatologist gave me a topical, but my general practitioner gave me the and
Hmm.
and the itching stopped, the bumps subsided.
Interesting.
So, and then I got a lot of stressed out, but I was just wondering if there was anything else.
Well, I think, there's so much about scleroderma that we don't know fully. And again, when you are under stress, if you do have an infection, I mean, clearly that can be making you worse. And so I think treating that properly, you might just be feeling, better. I think the other thing that has made this disease very hard to study over time is that there does tend to be the spontaneous improvement, and whatever a patient is taking at that time typically gets the credit. And yet, when you look in a double-blind way, it doesn't hold up. And that curve is the fact that there's these two complicated curves, and they kind of have different paths, has again really made the studies difficult. But when we do look at a lot of that stuff, it winds up not, working.
Yes. Dr. Connolly, I have limited scleroderma and morphia, but one of the things that happens is, you get this very itchy skin, and I do have a topical corticosteroid, but I wonder, do you have any favorite product that you can tell us, hey, this will really help you for washing or for something like that, because I go out there, I don't know about anybody else, my bathroom cabinet is full of all these things I try, and I really don't know, and I've had 3 different dermatologists who've told me 3 different things.
Yeah, I think it is so personal that it's hard to know, and it is. I mean, I salute you for doing the trial and error, because I think that's just what you have to do. And if you see a dermatologist or a doctor who gives you one thing, I mean, I think it's worth a try. If it doesn't work, let them know, and that there may be other things. Again, in terms of products, I like the sort of the Aveeno line of things. I think that they keep the pH, they have a good pH for their products. So I think Aveeno, which is made by Johnson & Johnson, are good lines. I like the Vanacream line, which you can get at Walgreens, or you can get it online from Vanacream. It's a little heavy for the men. They find it too heavy, but they have lovely sunscreens and lip products. And so it is such a personal things. Things I don't like are things like Eucerin. I think it's very tacky. I don't think it works very well. In terms of topical steroids, again, it's whatever you will use and can afford. I often just tell people to go to Walgreens again and buy whatever corticosteroid is over the counter. You'll see it comes as either a cream, an ointment, or a gel. You want to avoid the cream and gel and use the ointment, and that's the greasiest. And again, you just can try it with that and see if it helps or not. I have had patients say that they sometimes for a flare, when they're having a flare in a certain area, and if you have morphia and is active, then a much more potent topical steroid, like the strongest would be something like clopidogrel or timivate. So that is something you can use for the most potent. So there's really this whole range, and it is kind of a it is an art. It is a science in terms of what can work. But I think you're doing the right things by trying different things. I think forums like this, where you meet with other people who've tried things too, can
changed. And I don't know if you've heard of this in your field, but as a result, all of the teeth in my mouth are loose. Unknown to me, until I went to a new dentist, and she wouldn't touch me. And she referred me to a periodontist. And prior to this, I've had with my old dentist, excellent teeth, no problems, and now I've got a serious condition. And they said if I lose one tooth, I'll lose all of my teeth. Is this connected to the tissue in the sense of how it changes? Like, we talk about how it gets hard and pulls, and our mouths get smaller and things like that, but how about the tissue in your mouth?
Yeah, I would say yes, definitely it is also affected by this, and I think it is very complicated as you're suggesting, but it isn't. Some people have Sjogren's, and so they have a dry mouth. Yes. That gives rise to cavities that can make life sort of harder. But I agree with you totally. It's much more complex. There is this thinning of the whole tissue. It's a tissue deep dystrophy, and in that sense affects the whole mouth area. The mouth is a very, so it is the teeth and the mouth is very, very challenging, starting with getting that small mouth, and dentists have a hard time getting in there. We do have a dental school at UCSF, and we do have some dentists there who are really, they work with people who have more of these kinds of medical problems. So I have referred some of my patients for that. I'd be very careful about doing implants. I'd be very careful about doing any kind of surgery. I'd be very careful about, because you just you're much more sensitive. You have to be really careful about these things.
Well, a big thing is the cost. And one thing was do implants or pull every tooth in my mouth out. And I don't like the idea of either one. So I'm just doing everything I can. I wear a stent at night and a retainer on the bottom, and I brush 3 or 4 times. And I clean 4 times a year. So
Sounds like you're doing quite a lot.
I'm going on my own.
Yeah.
That's all I can say.
Yeah, there are, again, I'm clearly not an expert on this, but there are, again, and I know that there is some information on the website as well, but there are dentists, periodontists and stuff, and oral medicine people who have, again, written about and thought about the scleroderma problem. So I think, definitely seek out that type of, expertise.
Thank you.
You mentioned the program when one would go in on a Friday as a new patient. Do you have information on how one registers for that program?
Yeah, so this is our UCSF clinic, and we would be happy to see you, and it shows you how to register here. It's not totally easy here. I'll give you one. And then if we don't have extras, we'll put this on the website, or we'll get this out there for you. But you would be welcome to come and see us on a Friday.
Great, thank you.
Hi, Dr. Connolly.
Hi, how are you?
I love her. She's my doctor. She's the one who diagnosed me and saved my life, in the sense of knowing what I had and everything about 4 years ago. I'm doing pretty good. I haven't seen you in a while, and I have now my pigment is changing in spots, like the bony areas. Doesn't hurt, doesn't itch. Almost didn't even notice it until I thought, oh, what's that? So I was talking to some of my friends there, and they were saying you wear clothes that, now that summer and sun's coming out more, I'm feeling maybe it might be happening around my nose, so I don't want this white nose and dark skin. So is there treatment? Is there something I could do to prevent it from progressing faster, slowing it down? That's my question.
Right. Well, I think the pigment changes are very tricky. For one thing, I have not known, patients generally don't do well tanning to try to cover up the white areas. The darker areas tend to get darker, and the white areas, maybe get a little darker, but it still makes that unevenness. So people who've tried that have generally not been happy. I've had a lot of morphia patients try it just to kind of see if we can kind of get it to cover up. So I would say probably not. I would say not getting a suntan or opening your skin to the sun for that. I don't think you would have a good result with that. I think the makeup, so cosmetic stuff for scleroderma, I think we are moving. There are some benefits out there that do help us. The lasers, the special lasers for the telangiectasias that can be useful. Remember, again, it will come back. The lips that, I would always, again, I was very old, and when people started out with their little thin lips, I would say, you can't use collagen, right? Well, now there's all kinds of non-collagen-based products out there that people are getting injected in their lips, and they're doing okay. And since my patients don't listen to me when it comes to the cosmetic part of things, they come back, and I'm horrified, but I think it's sort of okay. So I think you can do the lasers. I think you can wear the makeups. I think doing all those sorts of things, and I think that those are important questions, because in all the studies, a lot of times it's like the thinning of the lips, bothers patients more than lung disease. So if you look at the studies that kind of look at how because you're looking in the mirror, every day, you're brushing your teeth every day, or whatever it is you're doing, you're encountering it, and that's what's bothering you. And so I think in that way you define what's important, and you define what we need to kind of focus on. But I think there are options out there, but sunning would not be one. Fake tan, maybe.
I have a question about not skin, but more the organ issue. I just had a total colectomy because the scleroderma had gone internally into my gut. And I'm on rituximab now along with the methotrexate. I have multi-connective tissue disease, so systemic scleroderma along with lupus. I know you said that the rituximab, you don't think that it works, but do you think it works more in that aspect? Dr. Wallace in Cedars-Sinai, I don't know if you're familiar with him. That's my rheumatologist. Yes. Have you, I guess I have a couple questions. How many patients do you have that have lost their colon? Because this was an emergency surgery. It happened, was completely out of the blue. And it just happened this Christmas. And so I haven't I'm trying to find other scleroderma patients that now have a ileostomy and whatnot, and I'm not having success so far with that. Do you see this a lot or not so much?
I can say no. This is how many patients who've had a colectomy that I know for their scleroderma. So I think what you experienced was extremely rare.
Okay.
Extremely unusual.
Oh, right.
So yeah,
Unfortunately.
I think Dr. Walls is a wonderful doctor, and so I think it's worth trying the biologics again. I didn't mean to kind of discount them. I think especially in a setting like yours where you have some overlapping features.
Yeah,
absolutely worth trying, and I think that's just fine to try.
He said out of 1 through 10 treatment, I'm on 10, right? The 10 is, shy of the stem cell transplant. So I'm just obviously don't want to go that route. I have 3 children, but. So, yeah, so I'm just trying to be a sponge and gain any information that I can because it happened so fast and it came on so aggressively, so.
Where do you, are you from Southern California?
No, I actually live in Fresno, but there isn't really I shouldn't say a qualified rheumatologist, but as sick as I was, they airlifted me actually from St. Agnes to LA, so.
To Cedars-Sinai?
Mm-hmm.
Wow. Ooh. Poor thing. I'm sorry you had to go
no,
through that.
It's just
like it was
trying
really
to find, the doctors that deal with.
So in your area, I would certainly look, again, I think it is worth pursuing maybe some specialists who have expertise in your area. So if you're having gut issues, then I would say go to see a gastroenterologist, and you may have to shop around a little bit because, again, sometimes they do one thing well, but not other things. But I would think it would be, really in your best interest to do that. The gastroenterologists also have their diseases that respond to the biologics as well. They have their approach. So I think incorporating some of that would be helpful. I think coming to something like this and then maybe going on the website. But what you're describing about the gut is very uncommon. The upper GI, everybody pretty much has it. The lower GI is less common. Certainly the lower GI needing to having sort of that catastrophic outcome where you had to have it all. That's very rare.
Because the biopsies came back positive for scleroderma in the gut, so they knew for sure it was from that. So
well, that's a fascinating story.
Thank you.
You mentioned that there were 27 lung transplants, scleroderma patients at UCSF. Is it after they had the transplants that they recognized that it was scleroderma? And I have a little bit more further question. I don't know, years and years ago, maybe 10 years ago, just in general talk, they would kind of be thinking, well, if you have scleroderma, that we probably wouldn't choose to do a transplant because whatever the process of a scleroderma, then you would create that process for the new transplant. But things, I know, shift so quickly. And so I was wondering if you could tell us a little more about that.
No, well, thank you. That's a really important question, and thank you for bringing that up, because one of our points by publishing the paper was our patients are doing as well. The scleroderma patient cohort was compared to the just all comers for lung transplants, and their 2 and 5 year survival is the same. And so having scleroderma should not be an absolute contraindication from getting a lung transplant. I know. Yeah.
How far back do you think it was that they recognized, oh, this was a scleroderma patient? 6 years ago or 10 years?
Well, it was a mixed bag of patients who all got their transplants through the lung department. So all I meant was that I think the lung doctor's abilities to diagnose scleroderma wasn't ideal. And when we went to publish it, we had to pull everybody's records to make sure we had the right diagnosis. And that's where, they didn't write the word sclerodactyly. They didn't write the word Raynaud's phenomena. They didn't look at the nail capillaries. They didn't do the ANAs. They didn't do the kind of stuff that we just do routinely. So that was my point about that.
But also, when you have interstitial lung disease and you meet other people, you find that some people, when they have had a transplant, they find out after the transplant it seems so easy that you can then determine that actually they had something different. So that's just
Right.
part of the process that once you have your lung taken out, then it's so easy to determine what, So it's not just scleroderma, it's in all ILD things, I think, that it's not always precise, right?
Correct.
Go ahead.
Hi, Dr. Connolly. First of all, on one of your slides, there was a notation that suggested no particular need for sunscreen.
Right.
Is that sort of a general rule, or?
Well, I as a dermatologist, we always have to say you should have sunscreen. But my message, so for just the reason you want to wear sunscreen is for to prevent skin cancer, and then also photo aging. Your skin ages. But scleroderma is different than, say, lupus or dermatomyositis. Those patients' rashes will flare in the sun. And so we spend a lot of time going over sun protection, sunscreens, the whole thing. So we have these whole handouts for those patients just focused on that. And when the scleroderma patient sometimes gets mixed in with that group of lupus dermatomyositis patients, they sort of get a whole bunch of information about sunscreen that's probably overkill, because usually the sun is okay. I mean, again, you should be using sun protection good for your skin type to prevent obviously don't get a sunburn and all the rest of it, but to our knowledge, you do not flare your disease by going in the sun, unlike lupus. But thank you for bringing that up. So maybe that slide was unclear, so I'll take it out or make it change.
Okay. Also, I've found in my own experience that in areas where my skin is slightly thickened, I don't tolerate having my skin wet for very long without it splitting. And I was wondering if you could say anything about what it is in the skin that's doing that, and if there's any particular direction from rheumatologists that says stay away from getting your skin wet.
Right. I think you have to, one of the hardest, kind of most difficult things people do is wet work, like dishwashing wet work. And I think just the heat of the water, the soap, and all the rest, it sort of strips all the fat and stuff out of your hands. And so I do think that does, and for scleroderma patients who already have Raynaud's, who already have bad blood flow, who may already have little ulcers, I think that is really difficult, is an added insult. So we usually do recommend that you use some kind of nice dishwashing wear, or try to, sort of, and make sure you keep your hands, again, as dry as possible, and then afterwards dry them off again. But yeah, I think the skin, it's the skin's reaction to water is abnormal, or whether it's in the shower or the sink or whatever. I think it just, the way it breaks up, the way it it moisturizes, I think it's different than other people's hands. And if you look at all those deep skin biopsies, I mean, there's all kinds of sort of changes there that we don't even talk about. There's the sweat glands. I think that makes a difference. There's a whole bunch of stuff that makes you more fragile.
All those little organelles are just getting sort of choked off by the sclerosis? Or?
Something like that. I mean, something like that.
Thank you.
Well, I just had a comment on that. What I think, I didn't realize this, but when I took a shower or bath, when I washed my hair, as of this year, I thought, oh my gosh, I should wear gloves. Because even though my hands get wet because it goes in, it's just the shampoo and just strips. And I just found that really helped. Also, every night I wear Aquaphor with cotton gloves. And that has made a huge difference also in trying to get moisture back. Because I noticed that when my glove falls off, the next morning my skin is really tight. Whereas if I have one off, one on, and then all of a sudden I'm like, oh, the other one's not perfect, but it does do leave, leave that. So.
Any other questions? Oh. Who was first? Did you raise your hand?
Hi, I just had a question about digital ulcers. I was hoping that you would talk about that in your presentation, but I've been so frustrated with this one finger right here. And I had this ulcer since December, and this is the first time I've actually gone through where I got an infection. And it was, green and yellow, and there was discharge, and so they put me on antibiotics, and so it seemed like it was getting better, and I feel like I'm going on this roller coaster ride because it goes up and down where I feel like it's healing, and then it starts hurting again, and it feels like the infection's coming back. I'm not sure if I'm on the right track for it to heal, and just to get your advice on that and any feedback, because it's I know there's no sure way of if you take this it's going to work, but just something that I can look out for, because right now, I saw my dermatologist, I saw my rheumatologist. I don't know if at this point should I go to a vascular surgeon or a hand surgeon or whatever to take a look at it. Just looking for some options.
Well, we did do the digital ulcer thing on the website. Right, did they come out in the newsletter? Yes. So I did write up a little thing. I did write up a little thing for the newsletter on digital ulcer care, but this is a huge, super important problem because it is on your hand, on your finger, and it's painful and gets in the way of everything. And so there is sort of a graded approach to that. So we start with the calcium channel blockers. We make sure that you're on the right dose. I like Norvasc, either 10, even to 20. And then you add the phosphodiesterase 5s to that. That's like your I'm saying protopic, I don't mean that. It's your Viagra family of drugs. So then are you on Viagra? You add on that, and then you can add even things like Truclear or Bosantin, things you add that to that. So you're adding this very vasodilatory effects. Do you work?
I do.
And what do you do for your job?
I'm a healthcare administrator, so I do a lot of typing. So I don't use this English, so
Yeah. Well, I think I think when you do work, we have nurses who wash their hands a lot, and that just makes the ulcers just get cold and difficult. So you want to definitely have a heater in your office. I think sometimes that stuff too. So there's the medical part of it. I wouldn't go to a vascular surgeon. I think that, again, with a rare, there might be, if that was really their specialty and you knew someone who had success with that. Like I know this plastic surgeon for the calcinosis at Stanford, but everybody else I would sort of shy away from, because it is it is really more of a systemic problem, and usually a bypass, the kinds of therapies that vascular surgeons can offer you probably really isn't something that would work for you or be a good idea. Wound care is incredibly important, and so again, I usually like some Metrogel, which is an antibiotic, sort of on the base of it, and then I put a Duoderm layer over that, the Duoderm, which is a hollow colloid Band-Aid, and we've learned that these ulcers usually do a little, if they're not infected, you have to have the infection treated, but if they're not infected, they do better under a moist container, and so the older kinds of wet to dry type of things that surgeons used to do for wounds and for ulcers, not a good idea. They make them more, so you do want to keep it moist, so you want to kind of find some way to kind of keep it clean and moist. And then so I like the Metrogel at the base, and then I go with I Duoderm thin, and you cut that out just a little bit bigger than the ulcer, and you put that backing on there. And then the key to the whole thing is paper tape. Otherwise, that baby's going to come right off. So you get that 1-inch paper tape at Walgreens, and then you go over it a few times snug, so you really hold it on there. Once it is on there, it actually can stay. Unless let it fall off naturally, it doesn't have, if you pull it off, that Duoderm adhesive, everything is supposed to last like up to a week. And we even do our diabetic foot ulcers with this approach. And we leave it on there for a full week. Oftentimes patients don't, they want to peek, they want to see, but usually if you can I would build up to a week, but I would start leaving it on there longer and longer and longer. And, as long, again, you have to not be infected. If it, finish the antibiotics, but do you feel like it's still infected, or did that get taken care of? Yeah. well, maybe you could take the antibiotics, along with this then, but then try to do the coverage. And I do find that system that, really patients do benefit from that if you can kind of get that whole thing together. And then, the Metrogel, helps the base of it stay non-infected, and then you kind of make this little sandwich. And it usually is very helpful. There are now also all sorts of fabulous new Band-Aids that you can buy over the counter, like Walgreens. And there are ones for the tip of the finger, and so you can look into that. I have some patients who like they use the, for you, since you're an office worker, they go to Office Max and they buy those finger guards there that you use for filing and stuff, and they put the finger guard on the top of that Band-Aid and do different things. And so you have to really, really work hard. Once this ulcer is healed, it seems like because you go through all that, you usually then sort of have a little break. Do you have just the one, or do you have others?
Actually, I had two on this finger, and one of them did heal, but I was still dealing with the other one. I do have, I have others on my finger, but they don't. Yeah. Well, and then the other thing is the Heat Factory. If you go online, and you guys all have your heat stuff here that looks so great, but I like the Heat Factory. I like their glove mitten hybrid. I like the fact that you can put the heating element right over the fingers, but looking at your wrist, the wrist support here, that looks pretty good. But if you want to get it more over your fingers for your Raynaud's, again, getting some protective gloves with a heating element in them.
Can I make a comment on that?
Yeah.
About the Botox and anything?
Oh, yes.
I just got Stanford to inject Botox because I had terrible ulcers and bone infections and surgeries, and I'm on all this stuff. And I just got 10 Botox shots in my fingers and my feet. So, and
Excellent.
Catherine Burke at Stanford, she's in with James Chang, would be a place to go. She was in with you. I'm the second.
So say her name again. Her name is Catherine.
C-U-R-T-I-N.
That's good to know. Okay, and she's with James. Good.
Can I ask
That's
a-
a very good group.
So it's a new thing, and we're trying to figure out how we're going to get paid for it.
Was it painful?
They did it in the outpatient and gave me sleeping meds.
Okay.
It was 10 shots in my hands, and I didn't feel it.
Great. Good. Thank you.
Quick question, sorry. Over here. So when I'm having the Raynaud's symptoms and the vessel spasm in my fingers, is that happening systemically? Am I having vessel spasm elsewhere in my body? And is that having...
Yeah, and there's a lot of people nodding their heads, but yeah, we do think that. We do think that when you see it in the fingers, yes, it is happening in other organs. And there have been studies years ago, like in the lung, that showed that it could happen there. And so the answer is yes.
Okay. And same thing with the swelling type symptoms? Swelling
That's a
in the
good
hands
point
and
too,
feet?
but the swelling, I think of that less in terms of being internal. The vascular stuff, I think of it being, could be your vessels sort of everywhere. Swelling, I'm not so sure about, but definitely the vessels.
Any other questions? Okay, we are running a little over, but no, you were first.
I have a question about the calcinosis. So it seems like if you have trauma, you end up with calcinosis. The problem is they end up being like little volcanoes. So they keep coming up toward the top of the skin, and they create so much pain that you end up picking them out just to relieve the pain. But then you get infected. So, like you said, there's nothing you can do to prevent them pretty much. And even if you try to sit with them and deal with them, you end up at a point where you're just trying to get rid of the pain. Have you found anything to prevent the infection quickly if it comes out or rolls out on its own, or you take it out, that helps? Because I feel like if we can prevent re-traumatizing the area, maybe they won't happen as often. And so anyhow, you're in that cycle, and what do you find out to help fix that?
Well, what you're describing is really common, and I hear patients, we say as doctors, don't pick them, right, because you're going to get an infection, but it's irresistible, or it's just, it sets itself up in a way that it just seems like it will relieve it in the short term. So what I would just say is that, if you are getting a lot of infections right after you pick it? Cycle. Have you tried a good topical antibiotic? Topical. You're on the triple topical antibiotics. Yeah, 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 yeah. But I mean, Kathy, you have a suggestion for?
Yes, we will have that online.
Yeah, yeah, yeah. And how to keep it from getting infected. I mean, it would certainly, with you, I mean, I would go through the different, there are sort of antiseptic things. So if you're always getting infected, I would really have to kind of go there a little bit with you about what are you doing with your hands? Do you have kids? Are you a gardener? I mean, why is this happening? Because most of my patients, even on mycophenolate, who admit to picking on the little calcium to extrude them to feel better, it's rare that they get an infection. So I am a little concerned about why that's happening in you so once in a while, fine, but all the time, which just makes me worry about how you are doing it. Maybe we need to give you some sterile needles, or just kind of go through how to prep the skin better. We use a lot of Hibiclens soap. Hibiclens soap is an antibacterial, and you get 48 hours of bacterial coverage. And so sometimes we would prep you like we would prep a wound to do surgery on. But that is unacceptable to be getting so many infections. And so there is something about your technique, because I don't hear my other patients. Again, once in a while, sure, it will get infected, and that's the one I hear about, but most of the time they do it with sort of impunity. And so I'm just wondering, again, about your technique, and the wound care person probably would be an excellent person, but I would use Hibiclens to prep it. I would, try to, again, put maybe, not use the triple antibiotic topical, but maybe use something like a Metrogel or Bactroban, a prescription topical antibiotic, again, right away, and, keep with that and stuff like that to see if you can prevent that from happening. No. No. Yeah, there.
Yeah.
Dr. Connolly, is there any relationship between the triggers as being like Lyme disease that triggers the scleroderma? And then there was also some information about that if we have the scleroderma, that there may be cancer on the horizon as well.
Right. I think, so I think when we think of what triggers scleroderma, there's sort of these two big pools. There's this environment coming together with some genetic predisposition on the host. And in that environment, infections like Lyme disease or other types of infections as possible triggers are there. More recently, I know Anthony Rosen at Johns Hopkins published a paper in Science looking at some of the autoantibodies and that cross-react with cancer patients. And so I think that they were looking at certain autoantibodies that looked like it was a cancer, triggered from a cancer, or had the same kind of signals as a cancer. So I think that there is a tiny increase, although I think in the paper it's more than I was aware of, but there is a tiny increase of cancer among scleroderma patients, lung cancer in particular. And so I think that again, was something that we sort of have to sort of think about, and so possibly is a trigger. There on the list of all the differential diagnosis stuff that I didn't really go into, there's a section called paraneoplastic, and so those are the things that when you have a cancer, can look like scleroderma if you have a cancer, and that's on that list. And so it is something that can be an association with fibrosis and that kind of stuff for sure.
Okay, we have one more question.
Can I just mention something about ulcers? Just using the word loosely, maybe sometimes they're a little abscess, and I mean, obviously I'm not a medical person, but when I thought I had an ulcer and I thought, well, big deal, turned out to be a little abscess. And is it not quite this simple, but if it is an abscess, then you do have to have a doctor actively drain it, whereas like when I had ulcers, I just, don't touch it and wait for it to heal. So
Right.
could some people be having abscesses and...
Sure, I think that's an excellent point. And again, I think it's something that's why it should be examined. So whenever your ulcers, I think you guys get to be pretty experienced with your ulcers, but I would say whenever it doesn't behave kind of typically, that would be an opportunity to look. We would worry about any time when there was extra redness there, more pain than usual. I mean, I guess it's hard to sort out some of the pain from the baseline ulcer versus from the one that's infected, but that would be something we would really want to know about.
Is there one burning last question? Okay. I'd like to thank you so much, Dr. Connolly. It has been so informative, and we appreciate your time.